Welcome to This Week in Hematology. This week we're covering 10 notable papers spanning bone marrow failure and myeloproliferative disease, blood-based disease monitoring in myeloma and lymphoma, and real-world outcomes with the targeted and cellular therapies we now use every day. Let's dive in. Let's start with two randomized trials in blood that both challenge a treatment ceiling. The EMAA trial, led by Hochman and colleagues, is the first placebo-controlled phase 3 study in moderate aplastic anemia, a group for whom no consensus first-line therapy has existed. 85 patients with clinically significant cytopenia were randomized to cyclosporine A with either Eltrombopag or placebo, and among the 75 patients evaluable at week 24, the overall response rate was about 71% with Eltrombopag versus roughly 43% with cyclosporine alone, a statistically significant difference on the primary endpoint. What makes this trial practically useful is what happened after unblinding. Placebo-arm patients who had not achieved a complete response were crossed over to Eltrombopag, and that group reached an overall response rate of about 74% by week 48. Again, a significant improvement. Relapse rate and failure-free survival did not differ between arms, and there were no new safety signals. So the actionable message is that adding Eltrombopag upfront improves tri-lineage response in moderate disease, and adding it later still rescues a substantial number of patients who failed cyclosporine monotherapy. Also in blood, Palmer and colleagues report the phase 2, impulsion study of sapablursen in polycythemia vera, an antisense oligonucleotide that suppresses TMPRSS6, raises hepcidin, and restricts iron availability for erythropoiesis. 49 phlebotomy-dependent patients received subcutaneous dosing every 4 weeks. Over the efficacy window, the median number of phlebotomies fell from 5 at baseline to 0 in the higher dose cohort, and about 1.5 in the 40 mg cohort. Symptom burden on the MPN symptom assessment score improved significantly in the higher dose cohort, but not in the lower dose cohort. Adverse events were mostly mild or moderate, with anemia and fatigue the most common, unsurprising given the mechanism. This is early phase data, but it points toward hematocrit control without cytoreduction or repeated venesection. Now to a theme that is quietly reshaping follow-up: can we monitor disease from blood instead of marrow? In blood, Dejois and colleagues used the structured sampling schedule of the Cassiopeia trial to compare serum MALDI-TOF mass spectrometry against bone marrow measurable residual disease by next-generation flow and next-generation sequencing in 237 myeloma patients with paired samples from post-induction through maintenance. At every time point, negativity by any of the three methods predicted longer progression-free survival with broadly comparable landmark performance. Agreement between blood-based mass spectrometry and marrow improved during maintenance, with strong positive and negative predictive value against a 10 to the minus 5 marrow reference. But rule-out performance was more limited against sequencing at 10 to the minus 6. Sustained negativity over 1 and 2 years identified favorable outcome patients regardless of platform. The authors frame this as complementary and phase-adapted. Use blood for frequent non-invasive monitoring during maintenance, and reach for marrow when you genuinely need maximum sensitivity. A parallel story comes from Hematology, where Gould and colleagues report real-world use of a commercially available immunoglobulin rearrangement, circulating tumor DNA assay in large B-cell lymphoma. Median turnaround from sample collection to result was 9 days, which matters for feasibility. After frontline immunochemotherapy in 102 patients, 12-month progression-free survival was about 15% when residual disease was detectable, versus about 85% when it was undetectable. That is a stark separation, and it was seen in routine practice rather than a trial-embedded biobank. The caveat is that we still lack randomized evidence that acting on a positive result changes outcome. So for now, this is prognostic information, not yet a treatment trigger. Our third theme is real-world confirmation and occasional refinement of therapies we already prescribe. In the British Journal of Hematology, the JIMA AML 2320 study prospectively followed 193 newly diagnosed patients unfit for intensive chemotherapy who received venetoclax with azacitidine or decitabine. Median age was 74, and over 4 in 10 patients were 75 or older. Composite complete remission was reached in about 3/4 of patients by the end of cycle 4, and median overall survival was 13 months. Two findings deserve attention. Achieving remission within 4 cycles was associated with roughly double the median survival, about 19 months versus 9. and patients who received the full 400 mg venetoclax dose without concomitant azoles did better than those on reduced doses with azoles, about 18 months versus 11. A matching adjusted indirect comparison with EMAA showed essentially identical median survival. That azole finding is observational and confounded by infection risk, but it should at least prompt you to revisit whether prophylactic azoles and dose reduction are automatic in every patient. Staying with acute myeloid leukemia, Kunath and colleagues in the same journal report 156 relapsed or refractory FLT3 mutated patients treated with gilteritinib across 25 centers. A heavily pretreated group in which more than half had relapsed after a prior transplant and nearly half had prior FLT3 inhibitor exposure. The remission rate was about 45%, with median overall survival of 10 months. The sequencing signal is the important part. Patients treated with gilteritinib alone had 1 year survival of about 34%, whereas those who proceeded to allogeneic transplant had 1 year survival between roughly 76 and 92%, depending on whether gilteritinib was resumed afterwards, and resuming it post-transplant produced a remission rate of about 86%. Selection bias obviously favors the transplanted group, but the practical framing holds treat gilteritinib as a bridge and then as maintenance, not as a destination. In myeloma relapse, EMN Italy contributes 306 patients who progressed on lenalidomide maintenance after autologous transplant, a population increasingly common and poorly characterized. Most received isatuximab, carfilzomib, and dexamethasone, and anti-CD38-based combinations outperformed the alternatives, with isatuximab, carfilzomib, dexamethasone achieving the longest progression-free survival at nearly 23 months. High lactate dehydrogenase, higher stage, and relapse within 12 months of starting maintenance all predicted worse progression-free and overall survival. This effectively documents the pre-BCMA standard of care, against which newer immunotherapies will be judged. Finally, 3 papers on immunotherapy delivery. From Hematology, Rocha and colleagues analyzed 1,191 EBMT-registered patients, aged 70 or older, receiving CAR T-cell therapy for large B-cell lymphoma, comparing tisagenlecleucel with axicabtagene ciloleucel, with median follow-up of about 23 months. Progression-free survival favored axicabtagene ciloleucel at the cost of more cytokine release syndrome at day 30. For a 74-year-old, that is a real trade-off to discuss explicitly rather than defaulting on age alone. In the British Journal of Hematology, Townsend and colleagues report Phase 1b, glofitamab added to obinutuzumab or rituximab plus CHOP in 31 patients with relapsed or refractory B-cell non-Hodgkin lymphoma. The complete metabolic response rate was about 84%, and median progression-free survival was not reached after 44 months, but toxicity was substantial. Grade 3 or 4 events in roughly 4 in 5 patients, cytokine release syndrome in about half, and 4 fatal events, mostly infections. And the Phase 2 DIST-INKT study of danberstotug, an anti-PD-L1 antibody, in relapsed or refractory extranodal natural killer T-cell lymphoma, reported an objective response rate of about 79%, with complete responses in roughly 2/3 of patients, and median progression-free survival of about 29 months in a very small cohort of 23. In a disease with few options, that durability is noteworthy, and PD-L1 membrane specificity looks like a candidate predictive biomarker. If you only have time for one paper this week, make it the EMAA trial in blood. It is the first placebo-controlled randomized evidence in moderate aplastic anemia, a setting where practice has been entirely opinion-driven, and it gives you both a first-line answer and a salvage strategy. Here are the key takeaways from this week in hematology. First, in moderate aplastic anemia, adding Eltrombopag to cyclosporine improves trilineage response, and late addition still rescues non-responders. Second, blood-based monitoring is maturing on 2 fronts. Mass spectrometry in myeloma and immunoglobulin-based circulating tumor DNA in large B-cell lymphoma both carry prognostic weight, but neither yet replaces marrow at maximum sensitivity, and neither has randomized evidence that acting on a positive result helps. Third, in unfit acute myeloid leukemia, early remission on venetoclax plus a hypomethylating agent predicts longer survival, and reflexive azole-driven dose reduction deserves scrutiny. Fourth, in relapsed FLT3 mutated disease, gilteritinib works best as a bridge to transplant with post-transplant resumption. And fifth, in patients over 70 receiving CAR T cells, axicabtagene ciloleucel gave better progression-free survival, but more cytokine release syndrome than tisagenlecleucel, a discussion to have patient by patient. That's your roundup for this week in hematology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary for clinical decisions. Always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.